Okay. So now, as I have mentioned earlier, this is the protozoal disease, and the name of this protozoa is entamoeba histolytica. And the characteristic features of these amoeba is that they move by means of false leg-like structures that is called as pseudopodia. And the clinical infections caused by these entamoeba histolytica is called as amoebiosis. And this in amoebiosis, the patient develops diarrhea, dysentery, basically in intestinal amoebiosis, and liver abscess as well as the abscess of other associated organs in the case of extraintestinal amoebiosis. And this the disease caused by these protozoal parasites is worldwide, but more common in tropical and subtropical countries, and in those areas where there is a poor water sanitation, poor personal hygiene, overcrowding, improper disposal of the night excreta, or improper sway system, etc., that I have mentioned earlier. These protozoa basically reside in mucosal and submucosal layer of our large intestine and cause the infections that is their habitat. Regarding the during the whole life cycle of these parasites, we can describe their three morphological forms. One is the trophoid form, another is pre-cyst form, and another is cyst form. I'll directly take you in this slide that will describe both the trophozoite, pre-cyst as well as the cyst form. These trophozoites are highly active and the feeding stage of the parasite that are highly motile by means of false leg-like structures. And when we see their detailed anatomy, then basically they possess two layers. One is the outer clear fluid that is called as ectoplasm. Ectoplasm, that is the transparent fluid that they have, and inner one is little bit granular and possess the nuclei also, that is called as endoplasm. These trophozoites forms move like as a jerky movement during their motility, and their size is around 20 to 25 micrometer in diameter, but they do not have distinct shape. Since they have the false leg-like structures, which is determined by the movement of these clear transparent fluid in those direction where that parasite has to move. Okay, so due to the presence of these pseudopod or false leg-like structures, which is basically mediated by this clear fluid transfer or the movement of this clear fluid on this side, these parasites do not have, or these form do not have distinct shape. Okay, and another is pre-cyst form, which is not shown in this figure because they are not uh, commonly demonstrated in the stool sample as well, even in the GI tract, because this pre-cyst form is the transition form between the cyst and the pre-cyst. So when environment starts to become unfavorable, then these trophozoites transform themselves into the cyst form via the pre-cyst form. In this case, these structures starts to become round with the loss of these pseudopod-like structures or with the loss of their motility, and their size got reduced. Okay, and after that, when the environment becomes unfavorable further, then they reduce their size completely. They become round, and all these structures got covered by a relatively resistant, thick, and highly refractile smooth cyst wall containing single nuclei when it is newly formed, and then two nuclei, and then quadrinucleated, or the four nuclei that they possess when it undergoes maturation. So that means this cyst form are round. Their size is around 10 to 14 micrometer in diameter, and this cyst form can be demonstrated in the stool of the infected person. The In case of watery diarrhea that happens in intestinal amoebiosis, or if there is the acute manifestations of the acute episode of diarrhea, then in those conditions, trophozoite can also be seen. But most commonly, the cysts are demonstrated in the stool sample, and which one is the diagnostic stage also. Okay. So this is regarding the morphology as well as the characteristic features of the trophozoite, precyst, and the cyst. So that means we can say these trophozoites do not have constant shape, but size is around 20 to 30 micrometer or around 35 micrometer in diameter. They are actively motile by means of this false leg-like structure that is called as pseudopodia. Okay, and they have the outer clear fluid that is called as ectoplasm. The movement of that fluid decides or determines the formation of pseudopod like structures and their movement, and they move or they have a typical jerky movement due to the presence or due to the with the help of this pseudopod like structure, which is the diagnostic stage during microscopy also. And another is the cyst phase, which is the infective stage also. And this cyst phase can be demonstrated in the stool of the infected portions. And this is relatively resistant stage for parasite themselves because they possess thick cyst wall, which is relatively resistant to changes in temperature, pH, and other extreme environmental conditions, and they can survive for days. Depending upon the environmental conditions, this cyst can become viable for days in the environment when they got excreted in the stool from the infected portion. The size is around 10 to 14 micrometer in diameter, and this is the diagnostic stage also. Okay, this is more about the morphology of this parasite. So now what happens, how they complete their life cycle, and what happens if we have the infections by this parasite. I will try to explain you in this figure which will make you more clear, and in the meantime I will try to describe pathogenesis as well as the life cycle, and which will be more clear for you to understand. Okay, so now we can start from here. Let's say from this stage, the newly infected, the infected portion loss more commonly the cyst and less commonly in acute diarrheic stool also the trophozoite in their stool in the soil. Okay, these trophozoites cannot further develop in the soil and it undergo degradation. But this cyst, which contains initially single nuclei and then two nuclei and the four nuclei in the environment or in the soil. In soil, they depending upon the environmental condition, in soil they can survive for days, 10 days. Let's say in warm, humid or moist environmental condition, they can survive up to or they can remain viable up to 6 months. During that time, this cyst got contaminated in your hand, in our food product, in our water, and finally we ingest them. Okay, the ingestion of these trophozoite cannot proceed or cannot proceed further as an infection because these trophozoites, even though we ingest, will be easily degraded by the acidic pH of the stomach. But the cysts are relatively resistant to the acidic pH of the stomach. That's why after ingestion, this cyst enters into our stomach, cross the stomach, and then reaches into the small intestine. Okay, they reaches into the small intestine. So now what happens in small intestine? Okay, in small intestine, what happens? This quadrinucleated cyst starts to have excitement. Here, what happens? The digestive enzymes that are present in the small intestine, for example, trypsin, act on the cyst wall, and the internal content of these cysts retract further. So that's why there will be the hollow structure in between the cyst wall and the inner content, and with the peristaltic movement of our intestine. Okay, this inner content hammer or hit on this wall, and this wall is already become weak due to the action by the digestive enzymes which are present in our small intestine. And finally, this cyst wall got ruptured, and from With the rupture of this cyst wall, the inner content of these cyst got released out. The process is called as excision. And with the release of these inner content with the cytoplasmic content as well as the four nuclei, this is called as metacystic amoeba. Okay. So now within that metacystic amoeba, these nuclei undergo mitotic division and becomes the number of nuclei become 8. And each nuclei will be punched out, okay, with the cytoplasmic content, and from a single metacystic amoeba, 8 amoebules will form. Okay, 8 structures will form, and each structure will transform into the trophozoite. Okay, so these incident happen in small intestine from existment to the formation of trophozoite. Up to these events takes place in small intestine. So now what happens? These trophozoites prefers to grow more in anaerobic environment. That's why they move further towards the large intestine, and they start to invade the mucosal and submucosal layer of the intestine, okay, and further multiply, and they degrade the intestinal tissue with the production of enzyme histolysin. It happens in the wall of the large intestine. Okay. So now what happens when this trophozoite got formed? They move to forwards towards the large intestine, and they starts to multiply by binary fission, and from single trophozoite large number of trophozoites formed, which is the very active stage as well as the feeding stage of the parasite. So that's why they start to feed on the intestinal wall by producing the enzyme histolysin. That's why the name histolytica has been given. These histolysin are the proteolytic enzymes that lyses the mucosal layer and then to submucosal layer. So now the mucosal and submucosal layer of our intestinal wall got destroyed due to the invasion of these trophozoites that elicits the inflammatory reactions here. There, since the mucosal cell got destroyed, some mucosal cell got destroyed, our immune system start to respond against them, and there will be the infiltration of the pus cells. There will be the secretions of the mucus, and there will be the infiltration of the RBC because the capillaries that line the intestinal wall got ruptured. So that's why there will be the blood or the accumulation of the RBC. Host start to respond to forms the inflammatory cells. That's why more WBCs will form, and the host start to respond against this parasite. That's why more mucus will be produced, and that's why there during that process there will be the formation of large ulcer that contains the debris of the dead mucosal cells, inflammatory cells, that is the WBCs, RBCs due to the rupture of the blood vessels or the blood capillaries over there, and the mucus secreted by the host. So that forms a large ulcer. And when our immune system are able to cope up, then to heal that ulcer, this whole material got evacuated in the intestinal lumen. Okay, so there will be the formation of ulcer, and that ulcer got evacuated in our lumen or intestinal uh, lumen. Then there will be the, and that content will comes out with our stool, and the patient will have blood and mixed blood and mucus mixed stool, and the clinical entity for this is called as dysentery. Okay, in this way the patient have blood and mucus mixed stool with urgency. Why urgency? Because such kind of ulcerations or simply ghau, okay, will be formed in different part of the intestinal wall. So that means there will be the multiple ulcer, isn't it? That's why the uh, autonomic nervous control for the defecation process will be affected, because since there is the multiple ulcer in the intestinal lumen surfaces, the innervated area for the defecation process, for the normal physiology of the defecation process will be inhibited due to the formation of such kind of multiple ulcer along the intestinal lumen. That's why the patient lost the control for the defecation process. That's why whatever be the content got evacuated in the intestinal wall, sorry, in the intestinal lumen, has to be come out. That's why the patient will have urgency. Once that ulcer got ruptured out and evacuated in the intestinal lumen, that has to be come out, which cannot be controlled by the patient. That's why the patient will have the urgency. Since there is the formation of multiple ulcers in the intestinal wall due to the invasion by the actively multiplying trophozoites, the patient will have the cramping, okay, and then penetrating type of pain, cramp, abdominal pain, or penetrating type of abdominal pain with urgency. So this is the typical clinical feature that we see in amoebiasis that comes under the clinical aspect. Okay, I am explaining both the clinical part as well as the life cycle of the parasite. So now what happens when is when host start to respond against these trophozoites, and when these trophozoites further do not get favorable environment for their multiplication, then what happens? They transform themselves into the cyst. Okay, when our immune system start to respond against them with the production of mucus, with the production of inflammatory cells, and when they feel or when they got some extreme conditions, then they transform themselves into the cyst form. Now, since this cyst is almost inactive form of this parasite, because in this stage they do not have any metabolic activity, and this cyst, and sometimes along with the trophozoite during the evacuation process of that ulcer in the intestinal lumen will come out of the stool when that patient pass the stool in the environment. And in the environment, this cyst initially will be single nucleated, and then to binucleated, and then to quadrinucleated. And only these quadrinucleated cysts are the mature cyst, which is the infective one. So now in the soil they undergo further maturation with the single nuclei, two nuclei, and then four nuclei, and it becomes quadrinucleated. And this quadrinucleated cyst can remain viable for days as well as sometimes in for months. And during that time, we may acquire again infection, and in this way the life cycle continues. So this is the life cycle as well as the pathogenesis of amoebiasis. Okay, so now we can, if we know this life cycle, as well as in between the life cycle, if we have the clear vision regarding their pathogenesis, then we can easily say what happens during that infection or what will be the clinical manifestation the patient may have. So since there is the invasion, we have the immune response, our immunity have certain response against that. That's why the patient might develop fever sometimes. Since there will be the multiple ulcer in the intestinal wall due to the invasion of these trophozoites, that's why the patient will have the abdominal cramp. Okay, the innervated area for the parasympathetic control or for the normal physiology of the defecation process will be affected due to the formation of multiple ulcer. That's why the patient will lost their control for the defecation process. That's why whatever be the content that got evacuated into the lumen has to be evacuated out. That's why the patient will have urgency or that cannot control the stool. Since during before that, while forming the ulcer, due to the invasion of the trophozoites in the intestinal wall, there will be the accumulation of the inflammatory cells, that is the pus cells, mucus, as well as the RBC, which will be evacuated out of the intestine uh, via the anus as a stool that contains blood and mucus mixed stool, that is called as dysentery. And now, since there is the multiple ulcer forms, the absorption, there will be malabsorption, isn't it? That's why the absorptive mechanism of the intestinal wall will be defected. That's why the patient might have diarrhea also. The diarrhea means if the patient pass loose stool more than 3 times a day, then that is called as diarrhea, which is the definition of WHO. So that's why the patient might have diarrhea and patient will have dysentery. So that's why if the intestinal involvement is only there, that is also called as amoebic dysentery. That means since the causative agent is amoeba, that is the protozoal parasite, and the patient will have blood and mucus mixed stool, that is called as dysentery. That's why the disease caused by it is called as amoebic dysentery. But similar kind of clinical manifestation, that is the dysenteric stool, will be will occur in the infection caused by certain bacteria, simply Shigella. That is called as bacillary dysentery. So since the clinical features as well as the nature of the stool that is seen in both the case are almost similar. So that's why we must be very careful to differentiate whether it is the amoebic dysentery or the bacillary dysentery, because the management for the amoebic dysentery and the bacillary dysentery is different, because there is a vast difference between the amoeba as well as the bacteria. Bacilli are the bacteria. Since the treatment aspect is different, we must be very careful to differentiate whether the patient is having amoebic dysentery or the bacillary dysentery. So for that, we have to uh, uh, know the differentiation between amoebic dysentery and bacillary dysentery. Okay, so this is important from examination point of view because it is most frequently asked in examination as ACQ or sometimes in MCQ also. The, these are the basic differences between the bacillary and amoebic dysentery. Here, the uh, number of stool pass is less than 10. In bacillary dysentery, more than 10. More fluid will be lost in this case in bacillary, but here less. The stool amount will be copious, here will be small. It will be very offensive, but in this case, odorless. The stool, blood and mucus mixed stool, such kind of features can be seen in bacillary dysentery, but due to the excessive number of stool pass or the diarrheic stool, in this case, the fecal material may not be seen in bacillary dysentery. pH is acidic in amoebic, pH is alkaline in bacillary. Postels will be scanty in this case, but numerous in this case. These are the basic differences between the amoebic and bacillary dysentery that we must know. Okay, so these are regarding the intestinal amoebiasis that I have described. Okay, but in some cases we have extra intestinal amoebiasis also. So that means while having invasion in the intestinal wall, okay, in some patient, these trophozoite cross the muscularis layer of the intestinal wall. I think all of you know the anatomy of intestinal wall that contains mucosa, submucosa, and the intestinal wall, isn't it? So now, these trophozoite most commonly can multiply or can degrade the mucosal and submucosal tissue only. They do not cross the intestinal wall because they cannot destroy the muscularis layer. But sometimes, which is the exception, in 5 to 10% of the cases, these trophozoites cross the intestinal wall and via the portal circulation, they reaches to liver and other associated organs. If they cross the intestine and enters into the extra intestinal area, then the patient have the extra intestinal manifestation that is called as extra intestinal amoebiosis. That is called as extra intestinal amoebiosis. In this case, in extra intestinal amoebiosis, the trophozoites will localize on that particular area. Let's say more commonly is the liver. In liver, these trophozoites reach to the liver via the blood circulation and starts to multiply there and form the abscess. Wherever they reach, whatever be the organ they reach, they multiply there and form the abscess. And the patient starts to develop the clinical manifestation. But the important point in this case is that Once these trophozoites reaches to that organ and starts to multiply, after sometimes they themselves got die. Because these trophozoites cannot develop into the cyst form in extraintestinal organ, which is accidental for them because they cannot develop further, but during the meantime we'll have the clinical manifestations and the complicated clinical features also, or the patient may die due to the formation of sac multiple ulcers in those organs. More commonly the patient will develop liver abscess, sometimes brain abscess, sometimes patient will have ascites due to this feature. Due to this extraintestinal amoebiosis, the patient have multiple abscesses. See here, multiple abscesses sometimes might have jaundice, sometimes anemic. Okay, so such kind of features can be seen in extraintestinal amoebiosis, which is comparatively more severe form, or the we can say the complicated form of amoebiosis. That's why the patient might have pneumonia, empyema, peritonitis, even liver abscess, sorry, brain abscess. Any organ where they reaches via the blood circulation, the trophozoite will multiply there, okay, and form the abscess. And according to the site involvement, the patient will have manifestation. This is regarding the extraintestinal amoebiosis. Okay, now another important point in this case, while talking about the clinical part, that is the amoebiosis, what happens? In most of the cases, the patient remain asymptomatic, which is very much important from epidemiological point of view, because these asymptomatically infected persons are the main reservoir or main source for control. Okay, because they are continuously shedding the cyst of these amoeba into their stool, and which could be the main source of infections. But it is known, it is very much clear that not all the infected persons develop the clinical manifestation. Only few of them develops clinical manifestations that basically depends upon the infectious dose and the host immune status and other condition. Okay. So now regarding clinical features that I have already explained you clearly, I think the patient will have diarrhea, dysentery, abdominal pain, tenesmus, that is urgency. Okay, and due to the severe diarrhea, the patient might have dehydration complications, and due to the dehydration complications, the patient may die. Okay, so these are the clinical aspect of the amoebiosis, right? Okay, so now prevention and control. I think all of you are clear how it can be controlled. The main problem in this case is the asymptomatic carrier and the infected person. If we could detect those asymptomatic carrier and infected persons and treat them earlier, then there is the less chances of dissemination of the parasite in the community, isn't it? So that's why the main preventive measures in this case is the early identification and treatment of the asymptomatic as well as the disease person, and and proper disposal of their fecal material. That is the main preventive measures. Similarly, other preventive measures, that is the environmental cleaning, hand washing, personal hygiene maintenance, okay, the boiling water, health education, particularly to food handlers in schools, in community health centers, because these can arise outbreak, isn't it? Because they could be the major source to have the outbreak. That's why these are the preventive measures uh, and control for the amoebiosis. There is no vaccinations, okay, there is no any prophylactic medications for the prevention of amoebiosis. The main preventive measures is the control of the source. Source is the asymptomatic carrier and the infected person. That is the main control. Second point is the proper disposal of the fecal material. That means the proper sewer system, proper water sanitations. Okay. And another is the health education, okay, to all peoples, community peoples, even school childrens, even in the people who is working in the community health centers. For them, we have to give the health teachings or the awareness program which are the preventive measures for this uh, disease. Okay, so now these are the basic differences between amoebic dysentery and bacillary dysentery. Okay, diagnosis. Diagnosis basically can be done by the demonstration of trophozoite and cyst in stool sample. So that means what we'll do in this case, we'll collect the sample, stool sample, we'll make wet smear preparation. That means we'll put a drop of normal saline over a glass slide and we'll take very little amount of stool sample and emulsify over that drop and cover it with the cover slip and then observe under the microscope. Okay, and in microscope we will look for the trophozoite and cyst of the uh, entamoeba histolytica. How we recognize trophozoite? Because they are relatively larger, they do not have constant shape, they have very typical jerky movement. Okay, and in this way we can came to know the trophozoite. Cyst, the size is around 8 to 10 micrometer. They are round with the very thick and refractile smooth cyst wall and four nuclei within it. Okay, based on that we can diagnose the disease. I think this is there, or you can uh, see this is the typical cyst that we can see. This cyst as well as this trophozoite can be demonstrated in the stool sample. Okay, you can look for the color diagram which is in Google also, or you can also have a look on book also, and we will show you in while we are having the practical sessions regarding these trophozoite and cyst. Okay, now the diagnosis is mainly by the demonstration of trophozoite and cyst of entamoeba histolytica in the stool sample by direct microscopy. Okay, that is the main diagnostic tool. The treatment mainly is the symptomatic management, that is the fluid replacement, blood replacement. Okay, and another is the killing of organism. So that is the use of metronidazole, isn't it? Because the metronidazole is the drug of choice to kill the trophozoite and cyst of entamoeba histolytica. That is the treatment part. Okay. So this is more regarding the amoebiosis. If you have any questions, then let's discuss for some time and then we can end our class. If you have any questions, then please. Do you have any question? Please let's discuss for some time and then only we will end our class. No, Ashish Saha already said no. So if you have any query, let's have some kind of chatting. Then we can end our class. Okay, may I ask you some question? How we can diagnose extra intestinal amoebiosis? How we came to know that the patient is having extra intestinal amoebiosis? Is there any options for the diagnosis? Yes, Ashutosh,
Yes, sir.
how can we diagnose extra intestinal amoebiosis?
Sir,
How can we diagnose extra intestinal amoebiosis? Colonoscopy, yes. Risha Bhaskar has said colonoscopy. Good. Colonoscopy, no. For extra intestinal amoebiasis, ultrasonography could be one option, which will uh, give you some hint regarding the formation of abscess in that organ. But that method is not sufficient to say that that abscess is due to entamoeba histolytica, isn't it? So for that, we have to take the sample from that affected organ. Let's say um, um, FNSC guided liver aspiration from that abscess. Okay, so there you will collect the pus samples from that abscess and try, and you will look or you will try to good. Yes, Karuna Shuhal has written needle aspiration of that organ. Very good. So that means you will have the CT guided FNAC, okay, and then you will collect the material. And in case of amoebiasis, in liver abscess case, you will have the anchovy sauce like abscess, and in that abscess, you will try to look for trophozoite, not cyst, because in that abscess, you will not demonstrate cyst. You will try to look for the trophozoite by microscopy. That could be the best option for the diagnosis of extraintestinal amoebiasis. In case of intestinal amoebiasis, uh, we can demonstrate stool sorry, trophozoite and cyst of entamoeba histolytica. Okay, as just Rishabh Bhaskar just mentioned that colonoscopy will help us to look for the ulcers. Okay, nature of the ulcer. I forget to mention these things that these ulcers will have typically the flag shape ulcer. Okay, such kind of flag shape ulcer can be seen by colonoscopy. We cannot say that ulcer is due to entamoeba histolytica because such kind of ulcer can be formed in our intestine due to other infection also. Okay, however, colonoscopy and the radiological examination will give some indirect evidence to rule out the case. But for the confirmation of the diagnosis, okay, for the confirmation of the diagnosis, uh, we have to look for either the trophozoite or the cyst from the clinical sample. Okay, that's all. If you have any more questions, then let us discuss. Otherwise, we'll end our class. Do you have any question? Okay, then thank you.
Thank you, sir.